Good afternoon. I am Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Philips and Sachs Communications, we want to thank all of the frontline workers in our audience for your commitment and passion in helping all of us through this very difficult time. We are truly, truly indebted to all of you, so thank you. I do want to show our audience also how you can send questions in throughout the webinar. Our speaker will try to answer as many questions at the end of the presentation. So to ask a question via the web presentation, please type your question in the box on the right-hand side of your screen and click Enter. And as a reminder, handouts for this presentation are available at the bottom of the web page you are currently viewing. Our moderator today is Dr. Sheila Weaver. Dr. Weaver is Associate Professor of Clinical Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at Temple University. She is the Director of Sleep Fellowship Program at the same hospital. Her specialties include pulmonology, critical care, and sleep medicine. Dr. Weaver is an active member of several associations, including the American College of Chest Physicians and the American Thoracic Society. Dr. Weaver has been awarded the Sol Sherry Award for Excellence in Clinical Research. Welcome, Dr. Weaver. I will turn it over to you.
Thank you, Monica. Good afternoon, everyone. Thank you for that very kind introduction. The title of today's webinar is Sleep Disorder Breathing in Hospitalized Patients, Diagnosis and Management. Speaking today on this very timely topic is a colleague and friend, Dr. Samuel Kratchman. Dr. Kratchman is Professor of Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at Temple University and the Director of the Sleep Center at Temple University Hospital. In addition to his focus on sleep disorders, his clinical practice includes pulmonary disorders such as asthma and COPD. His research has centered on the exploration of sleep disorders in patients with congestive heart failure, emphysema, and those on long-term ventilation. For more than 6 consecutive years, Dr. Kratchman has been recognized in Best Doctors in America. He's published extensively in several peer-reviewed journals and has lectured nationally and internationally on sleep-related topics. Our speaker has disclosed the following: he has no relevant financial relationships. This activity has been approved for continuing education. It is approved for 1 contact hour for nurses and respiratory therapists. The accreditation statement is listed here. And support for this educational activity is provided by Philips. At this time, I'd like to turn the presentation over to our speaker, Dr. Samuel Kratchman.
Good morning or good afternoon, everybody, and welcome to this webinar on sleep disorder breathing in hospitalized patients, diagnosis and management. This is an area, we are always talking about outpatient diagnosis and treatment of sleep apnea, but there is not a lot that has been talked about in regards to the prevalence of inpatients in regards to sleep disorder breathing, and maybe even diagnosing while they're in the hospital as well as treatment. So the learning objectives for today's talk is to describe the nature and incidence of obstructive sleep apnea in patients that are hospitalized, and discuss approaches to identifying sleep disorder breathing in this inpatient population. And then finally, to look at options for managing starting therapy in these patients while they're in the hospital and as they get discharged and transition to home. So let's start with definitions first. What is sleep disorder breathing? Well, it's really an umbrella term that includes a number of obstructive and central sleep apnea, diagnoses as well as hypoventilation syndromes. We're going to primarily discuss obstructive sleep apnea in regards to inpatient populations that we're going to talk about today. And I also am going to include obesity hypoventilation as one of the hypoventilation disorders. And I'll show you why in just a little bit. It's mostly related to the high prevalence of obstructive sleep apnea in this patient population. So a little bit about obstructive sleep apnea. For those that maybe haven't had the exposure in the lab as a technician, or if you're a nurse or respiratory therapist that is just becoming associated with the sleep lab or sleep disorder breathing, an obstructive apnea is an episode where there's a complete lack of airflow measured at the nose or mouth, but with continued effort with bands that we measure at the rib cage and abdomen to look for continued effort. But because the airway is obstructed, there's no flow at the nose or mouth. And it's usually terminated with an arousal. And following this episode where the breath is being held, there's an oxygen desaturation that follows it. An obstructive hypopnea is a partial obstruction of the airway. The airway isn't completely closed off, but there's a decrease in the airflow at the nose and mouth by at least 30%, with continued effort to try to breathe during this event. Again, usually followed by an arousal and an oxygen desaturation at the termination of the event. Now, based on those events, we will categorize obstructive sleep apnea as mild, moderate, or severe, depending on how many events an hour are seen. So mild is 5 to 15, 15 to 30 is considered moderate, and greater than 30 events an hour, we would determine that as severe obstructive sleep apnea, based on definitions from the American Academy of Sleep Medicine and the Sleep Heart Health Study that determined these mild, moderate, and severe categories. Now, with obstructive sleep apnea, the common symptoms include excessive daytime sleepiness due to these multiple repetitive obstructive events leading to arousals and disrupted sleep. The patient complains of sleepiness during the day, loud snoring, often complaining of waking up and having nocturia during the night, nighttime awakenings, again related to awakening from some of these events where they're fully awake, decreased libido, especially in males, complaints of GI reflux, and nocturnal sweating. Now, looking at the prevalence of obstructive sleep apnea, the original study that really looked in the general population, it showed a prevalence in the patients aged 30 to 60 years of age, originally with greater than 5 events an hour with associated symptoms of daytime sleepiness. Overall, 2% of women and 4% of males were determined to have obstructive sleep apnea. This original study that was done back in 1993 was followed up, and 20 years later, the prevalence of obstructive sleep apnea has shown to increase significantly, where presently, if we look just at moderate to severe obstructive sleep apnea, 7% of women and 14% of males now have what we would call moderate to severe obstructive sleep apnea. And this is related to the fact that the obesity epidemic has significantly increased the prevalence of obstructive sleep apnea. Now, obstructive sleep apnea has been associated with significant cardiovascular diseases, including hypertension, coronary artery disease, congestive heart failure, atrial fibrillation, and stroke. It's also associated with other disease states such as diabetes and COPD, and therefore a lot of chronic medical diseases have been associated to obstructive sleep apnea. Now, undiagnosed sleep apnea can have a significant economic cost, as shown here in this slide. Work-related accidents, motor vehicle accidents, lost productivity, as well as comorbid diseases, and possibly their association with obstructive sleep apnea leading to hospital admissions and readmissions. In this one study from 2015, it showed the total cost of undiagnosed obstructive sleep apnea being $150 billion that was associated with it. Now, I want to also, as I mentioned, include obesity hypoventilation in this discussion because of the high prevalence of obstructive sleep apnea. Obesity hypoventilation is defined by an elevated PCO2 of greater than 45 millimeters of mercury on an arterial blood gas associated with obesity, defined as greater than a BMI of greater than 30, with other causes of hypercapnia excluded. And most patients with obesity hypoventilation have obstructive sleep apnea. 90% will have an index of greater than 5 if they have a sleep study done, and actually 70% will have severe sleep apnea, meaning their index is greater than 30 events an hour. So the majority of obesity hypoventilation patients have obstructive sleep apnea. And I'll explain why we're going to include that when we look at the prevalence of sleep disorder breathing in hospitalized patients. Now, one of the big problems in medicine today is the readmission rate. And because of the readmission rate, hospital and overall medical costs have significantly increased. This one study from the New England Journal of Medicine, which was published back in 2009, looked at Medicare patients and their prevalence of readmission in that one-year period of 2003 to 2004. And you can see, depending on the state, but overall, approximately 20% of discharged patients were readmitted within 30 days of their discharge. And usually the reason that they got readmitted was the same underlying disease that led to their first initial hospitalization. So in other words, if they were admitted with an acute exacerbation of COPD and they got readmitted within 30 days, it was usually because of their COPD that led to them getting readmitted. Again, the same example, if they were admitted for heart failure, their readmission again was usually due to the heart failure again. But overall, the costs related to readmission equaled $17 billion in that 1 year, 2003 to 2004. So you can see the medical costs associated with readmissions. Now, that leads to the question if these chronic medical conditions are such a burden to the healthcare system, and they're linked to hospital readmissions with a 20% readmission rate. And yet these chronic medical conditions also, if they have a high prevalence of sleep disorder breathing associated with them, could the sleep disorder breathing itself be contributing to this high hospital readmission rate? So with that, let's look at the three questions that we're going to try to answer here today. First of all, is there any data looking at the prevalence of sleep disorder breathing, in particular obstructive sleep apnea, in hospitalized patients? And then number two, is having sleep disorder breathing actually a risk then for hospital readmissions? And finally, does initiation of treatment of sleep apnea lead to a decrease or an effect on the readmission rate and overall outcome? So let's first look at the first question. Is there any data looking at the prevalence of sleep disorder breathing in hospitalized patients? One of the original articles back in 2008 to look at this was really a retrospective study. They looked at 94 inpatients that had come into the hospital for a medical reason, but the house staff or attendings were suspicious for obstructive sleep apnea, and it led to them actually ordering an in-lab sleep study while they were in the hospital. And it was found in this study, something's happening with the slides here. Hold on one second. I think somebody is touching them. Sorry about that. They found that the prevalence of sleep disordered breathing in this retrospective study, that 77% were found to have sleep disordered breathing based on their inpatient polysomnogram study. And most of them had obstructive sleep apnea. The most common diagnosis that was associated with their admission was congestive heart failure and COPD. Again, they had a suspicion, and this is a retrospective study, but look at the high prevalence of sleep disordered breathing in these patients, 77%. And it seemed to be significantly associated the presence of obstructive sleep apnea based on their BMI, which you could imagine to be true. In other words, the heavier you were, you can see where the BMI was 40 or more, the prevalence of obstructive sleep apnea was significantly increased. So a high prevalence in these inpatients that were suspected to have sleep apnea. Another study that was more of a prospective study looked at cardiac patients that were admitted with decompensated congestive heart failure. And this is a study done by Rami Kayat, who is a friend of mine, who's at UC Irvine right now. And he looked at 395 patients that were admitted with decompensated heart failure. And while they were in the hospital, they had a sleep study using what we call a type 3 device. And I'll show you what these look like a little later in the talk. And what he found was that 75% of these patients that were admitted with decompensated congestive heart failure had sleep disordered breathing when they had their overnight study. And most of these patients actually had obstructive sleep apnea, as you can see, rather than central sleep apnea, which we can see in heart failure patients such as Shane Stokes' respirations. So again, a high prevalence of sleep disordered breathing. The initial retrospective study showing about a 70%, here 75% of inpatients with congestive heart failure having sleep disordered breathing. Another study that looked at just generalized hospitalized patients, admitted for different medical reasons, being COPD, diabetes, hypertension. This was a prospective study that looked at patients that were older than 50, and they based the diagnosis of obstructive sleep apnea in this case based on a Berlin questionnaire. This is a questionnaire that's been validated to correlate with the presence of obstructive sleep apnea, and they found that based on the questionnaire, 40% of these over 400 patients who were given the questionnaire had obstructive sleep apnea suspicion, very high suspicion based on the questionnaire. And while these patients were admitted, they gave the patients that had suspected obstructive sleep apnea an actigraph to wear, and also gave them a questionnaire that looked at sleep quality, a Pittsburgh Sleep Quality Index. What they noted was that the patients that had obstructive sleep apnea based on the Berlin score have worse sleep on their actigraph and also worse sleep subjectively based on the Pittsburgh Sleep Quality Index. So again, a high prevalence in this inpatient population of generalized hospitalized inpatients, 40% in this case, again, showing many patients with underlying medical conditions having obstructive sleep apnea diagnosed or suspected while in hospital. This is a very interesting study that just came out this year that looked at the prevalence of inpatient obstructive sleep apnea in patients that survived a medical emergency team response. So in those patients that survived after like a rapid response, they were given a questionnaire, in this case, a stop bank questionnaire. And based on the stop bank score of greater than 5 to 8 as being high risk for sleep apnea, they found that 50% of them were at high risk for obstructive sleep apnea, and only 38% of these had previously been diagnosed with obstructive sleep apnea. So again, based on questionnaires or actual in-hospital sleep studies, a very high prevalence of inpatients are found to have obstructive sleep apnea, most often not previously diagnosed. Now, I want to bring up this one study looking at obesity hypoventilation and its prevalence in hospitalized patients, again, for the reason that I mentioned earlier, because the majority of these obesity hypoventilation patients have associated obstructive sleep apnea, including 70% of them having severe sleep apnea. In this one study that was done in obese patients that were hospitalized, it looked at 150 patients with a BMI of greater than 35, and 31% of them were found to have obesity hypoventilation based on their PCO2 being greater than 45 on their arterial blood gas, and no other associated cause that would cause their hypercapnia. And what they found was that these patients that had obesity hypoventilation, they were more sleepy than those obese patients that didn't have obesity hypoventilation, and there was a higher rate of ICU admissions in this patient population, and they were also more likely to end up on mechanical ventilation. And in fact, the mortality rate in these obesity hypoventilation patients, again, most of them having associated obstructive sleep apnea, was significantly higher at the end of 18 months, 23% versus 9%. So after looking at that data, we can appreciate the fact that patients that get hospitalized with underlying medical diseases have a high prevalence of sleep disordered breathing, and in particular, obstructive sleep apnea. So let's now look and see if having obstructive sleep apnea found while in hospital is a risk factor actually for hospital readmission, and may be contributing to that slide that I show you on the 20% readmission rate and the $17 billion associated with it that the New England article showed back in the mid-2000s. So the first study that I want to go over here is a retrospective review over a 2-year period of a very large number of discharged patients. You can see at the top of the figure, this looks at more than 22,000 patients that were discharged, and whether or not they had a known diagnosis of obstructive sleep apnea at the time of discharge. And you can see that in those patients that did have obstructive sleep apnea, the readmission rate in those patients that had obstructive sleep apnea was significantly higher than in those without obstructive sleep apnea. So it seems to point to the fact that if you have known obstructive sleep apnea, your chances of getting readmitted are significantly higher than those without obstructive sleep apnea. And in this study, the odds ratio of getting readmitted with obstructive sleep apnea was 1.5. So if you can see, compared to other disease states that are listed there that were also associated with you getting readmitted, including COPD or congestive heart failure, this is very close, especially to atrial fibrillation and COPD, as a risk factor for being readmitted. So we know the prevalence of sleep disordered breathing is high in inpatients, and now some of this data is pointing to the fact that it may be a risk factor for readmission. This study also is looking at readmission risk if you have associated obstructive sleep apnea, and this study just came out this month in CHEST, which is looking at patients that got admitted with COPD for an exacerbation, and these patients had no known previous diagnosis of obstructive sleep apnea. And while they were admitted with their exacerbation of COPD, they were given the stop bang questionnaire to see what their risk for obstructive sleep apnea was. And if it showed a high risk for sleep apnea, they then overnight have what we call a high-resolution pulse oximeter, which I'll show you in just a little bit what that looks like, or a portable sleep test. And what they found was that having obstructive sleep apnea, based on the test results, led to a higher 30-day readmission rate than those that did not have obstructive sleep apnea. You can see on the left of the slide, 45% of those with obstructive sleep apnea were readmitted versus 19% that didn't have obstructive sleep apnea. And the severity of your obstructive sleep apnea also increased your chance for readmission. Those with worse sleep apnea, severe sleep apnea, had a higher readmission rate. So what is the effect then, since we can see here from these few studies that the readmission rate is higher if you have associated obstructive sleep apnea? If we treat these patients with known sleep disorder breathing, will it affect the readmission rate? Because that would be our goal, when it try to decrease their chances of coming back in the hospital. In this initial study that was really a retrospective review, over a 2 to 5 year period, the results show that in those patients that while they were in the hospital that had an oxygen desaturation index while wearing a pulse oximetry overnight of greater than 10 events an hour, if this group was looked at retrospectively, they looked for people that were then put on CPAP while they were in the hospital versus a control group that did not get put on CPAP and sent home on it. And they had 62 patients in both the CPAP group and 62 patients in the control group. Again, this is a retrospective study. And in this study, they found no difference if you had gotten treated with CPAP versus if you didn't in regards to hospital admissions, number of ER visits during that period of time, or unscheduled clinic visits, which are shown in the graph on the left. So in this retrospective study, there didn't seem to make a difference in whether or not you initiated treatment in hospital on these patients. But again, this study is a retrospective study. There might have been reasons that the patients weren't put on CPAP in the control group. A lot of problems when you're looking at a retrospective study. There are other benefits, though, and we're going to get back in the next slide to look at studies that have looked at whether initiation of treatment will make a difference or not in the inpatient setting. But there are other benefits that can occur when you initiate treatment in the inpatient setting. This is another study from Rami Kayat that looked at decompensated heart failure patients that had a type 3 device used to do a sleep study on day 1 or 2 of admission. And there were 23 patients that got treated with CPAP and 23 that acted as control patients that, based on their sleep study, did show an apnea-hypopnea index of greater than 5 events an hour. And it showed that in the patients that received CPAP, they had a significant increase in their left ventricular ejection fraction just after 3 days of use. So besides its effects on maybe readmission, there are other benefits of initiating therapy with CPAP in these patients when they're initially diagnosed as inpatients. Getting back to initiating treatment and whether or not it has an effect on readmissions, this is a study from the Penn group that looked at inpatients that were admitted with heart failure or atrial fibrillation. And based on questionnaire data, they had a sleep study with a type 3 device while they were in hospital. And then those that were found to have obstructive sleep apnea, they were discharged on an auto-titrating CPAP device. In their study, 86% of the patients that were studied were found to have sleep apnea. And what they found was that in regards to their 30-day readmission rate, those patients that were compliant with their CPAP after discharge had a significant decrease. In fact, they had no readmissions, that's the green line, at 30 days compared to the group that didn't use their CPAP, or what they called partial users, meaning they didn't use it for at least 4 hours a night, 70% of the nights of the month. So it showed here that having sleep apnea, if you're initiated with therapy and you're compliant with therapy, it will significantly decrease your readmission rate. So it's very supportive of the idea, let's try to find these patients while in hospital and consider initial treatment and continue treatment at discharge. So finally, as far as data here, I want to show you the effects of sleep disorder breathing, especially in regards to treatment, how it might even affect mortality, let alone readmission rate. In this one study from 2017, they looked at obese patients that were screened for sleep apnea over a 3-year period. If they had, based on a questionnaire, again, the stop-bang questionnaire, obstructive sleep apnea, they then either had an overnight high-resolution pulse oximetry done, or they used a type 3 device to see if they had obstructive sleep apnea. And then if their ODI, their oxygen desaturation index, suggested obstructive sleep apnea, or their type 3 device showed that they had obstructive sleep apnea, they all eventually had an outpatient polysomnogram. And what they noted was that in the patients that were compliant when they were initiated on CPAP therapy, had a significantly lower mortality rate if they were compliant with their CPAP. And what's notable in this study is the mean follow-up was quite long, 609 days. So you really got an idea and the ability to look at mortality by following the data that far out. Another study is that article that I mentioned that just came out in Chest, looking at the overlap patients that have COPD and obstructive sleep apnea. And it also shows that, survival can be affected based on whether you're diagnosed inpatient with obstructive sleep apnea or not. This looked at 180-day mortality. So these patients that were admitted, we already showed that if they had obstructive sleep apnea, the prevalence was quite high, in those patients with COPD. But based on, after discharge, those patients with sleep apnea compared to those in the blue that didn't have sleep apnea, at 180 days, the mortality was actually affected. So it kind of also pushes you to the idea of you wanting to diagnose these patients in hospitals, support that idea, and maybe initiate therapy and then follow them up as outpatients to make sure that they are compliant. So let's talk now about the inpatient program, the idea of having an inpatient program for the diagnosis and treatment of obstructive sleep apnea. What would we need to have such a program? Because there is no formal guidelines right now, as I'll show you, for having that kind of program. Well, first of all, I want to talk to you about the kind of devices that I've been mentioning in the literature here. These are examples here, the diagnostic devices that you would use on these inpatients. Most commonly are the type that we use for home sleep testing, which is a type 3 device. So that includes, as you can see in the picture on the left, the Alice PDX is one, the Knox T3 is one that often used, and the Watch PAP1, which is one that is worn on the hand and uses the finger to measure arterial tonometry, which is a different way of measuring for sleep apnea, and also has an effort sensor that's placed on the chest. These devices, especially the Alice PD, for instance, you can see in the picture, looks at nasal flow or flow at the nose and mouth. It will measure effort with the band around the rib cage or abdomen, and will measure pulse oximetry in there for heart rate. These will also be able to pick up snoring during the night. So these are the type 3 devices, or the WatchPAT-1, which uses tonometry, that can be used to diagnose inpatients very simply whether they do or don't have obstructive sleep apnea. The other thing that I mentioned that's used in a lot of these studies was the high-resolution pulse oximetry. So the one that was used in many of these studies is the Nellcor. This is one of the types that will measure and look for that oxygen desaturation index, the number of times that you'll desaturate to 3 to 4% for at least 10 seconds, and measure an index of that through the night using some software to evaluate for that. So these are the kind of devices that we would use in hospital to try to make a preliminary diagnosis for obstructive sleep apnea. Now, the correlation between the oxygen desaturation and the apnea-hypopnea index has been looked at, for people that feel a little leery of basing a diagnosis of obstructive sleep apnea just based on the oximetry that's recorded in the index during the night. This is a study that showed 680 patients with an oxygen desaturation index of greater than 5 an hour that had a subsequent discharge polysomnogram study, and there was a strong correlation between the oxygen desaturation index measured with pulse oximetry and the apnea-hypopnea index based on the polysomnogram study, with a large area under the curve to support that. Now, as far as guidelines for an inpatient program, the problem is there really aren't any that exist. There are some that recently came out for obesity hypoventilation, but this doesn't include obesity hypoventilation, all patients with obstructive sleep apnea. In those patients that were included with obesity hypoventilation in those guidelines, they did address the idea of discharging patients on PAP therapy prior to confirming a diagnosis with a formal polysomnogram study. And they noted that there were no good studies for hospitalized patients with obesity hypoventilation, but what they did note was that in hospitalized patients with suspected obesity hypoventilation, 17% of those discharged on PAP therapy died without PAP therapy, died at 3 months, versus 2.3% who were sent home on PAP therapy. And their recommendations were that since 92% of those discharged were discharged on BiPAP, they actually recommend for hospitalized patients with obesity hypoventilation that were initially diagnosed in hospital, they be put on like a BiPAP or bilevel PAP at the time of discharge. Again, this doesn't address the majority of people with obstructive sleep apnea that are inpatients, but there isn't any formal guidelines right now in regards to that patient population. So guidelines for inpatient obstructive sleep apnea diagnosis and treatment are needed. And this is an area, again, that is relatively not been looked at very well. Again, the obesity hypoventilation, yes, based on PCO2 values that are gotten while in hospital, showing an elevated PCO2. But for what we've reviewed today, looking at inpatients with comorbidities that have suspected obstructive sleep apnea, looking for just obstructive sleep apnea outside of obesity hypoventilation, we need guidelines really to show us a program to follow here for diagnosis and initiating treatment, as it may lead to some benefit. So what do we need to have a program like that? Well, we need people like you. We need dedicated nurses that are educated about sleep disorder breathing, and also the use of these validated questionnaires such as the STOP or STOP Bang, just to mention a couple. We need a dedicated respiratory therapist team that's familiar with doing overnight high-resolution pulse oximetry or putting patients on a type 3 device to do a portable sleep test. And then we also need these respiratory therapists to be familiar with initiating PAP therapy. Many of them are used to putting patients on bilevel PAP in the ICU or on the floors, like we do here at Temple. But how about putting them on an auto-titrating CPAP and acclimating them to a mask and giving them a choice of mask that they may be able to be sent home on? And then also to have a sleep specialist consult team for us to be called to help determine the patients who should be initiated on therapy and followed up as outpatients in the sleep clinic. Relative contraindications to doing inpatient testing would be if oxygen requirements on the patient are more than 2 liters a minute. You can see how that can affect an overnight pulse oximetry reading if you're trying to use that method to diagnose sleep apnea. If they have an underlying medical condition that's not yet been stabilized, like if they have a COPD exacerbation, which has really not been turned around yet to make the patient more stable. If they have severe insomnia, where they're staying up, during the night, and putting them on even a T3 study, and they're awake the whole night is really not going to be helpful to diagnose obstructive sleep apnea. And if they're getting frequent medications like continuous NEB treatments or every 2-hour NEB treatments, that also is going to interfere with testing. And frequent tests such as lab draws or x-rays that may happen at night and mess up the ability to really determine whether or not they do have obstructive sleep apnea. These are relative contraindications. The initiation of PAP therapy in inpatients could be considered if their ODI or AHI is greater than 15 events per hour, or if their ODI is greater than 5 events per hour and they have associated oxygen desaturation to less than 89% for more than 5 minutes during the entire study. And then initiation of therapy, as I mentioned, would be helpful with respiratory therapists that can mask fit patients appropriately and allow them to acclimate to the mask. And then determining if they're going to go home on auto-titrating CPAP versus after using auto-titrating for a few nights, some like to change to a fixed pressure. I think most of us these days would go with just auto-titrating as a method of initiating therapy and discharging them on that setting. And then outpatient follow-up is also important. Once these patients are diagnosed in hospital and initiated on therapy, it's important that they follow up with a sleep specialist. This will allow us to look at and interrogate their CPAP device to evaluate if their AHI is still residually high, and also look at their compliance data, because as we had shown earlier, compliance really can affect the readmission rate as well as their overall outcome in regards to treatment of their obstructive sleep apnea. And then based on that evaluation, determine if there's a need for a formal in-lab study. Let's say the residual AHI is too high. Do they need to come in for a split night study or a CPAP versus bilevel PAP titration study because of a residual high sleep disorder breathing AHI. So as far as proposed algorithms, and like I said, the literature is not been very strong in looking at the idea yet of inpatient diagnosis and treatment, because I think people are just starting to think of this more. But there is a proposed algorithm for this that has been suggested by Sharma's group, and Dr. Gupta laid out one here in this review for heart failure patients that get admitted with suspected obstructive sleep apnea. And if based on a questionnaire that suggests that they may have underlying sleep disorder breathing, it may lead to them suggesting then that a high-resolution pulse oximetry or portable sleep test be conducted overnight. And if it shows evidence of obstructive sleep apnea based on an ODI being elevated or an AHI if we're using a type 3 device, then based on this suggested algorithm, treatment should be initiated, again, maybe with auto-titrating CPAP following an acclimation to the different type of masks for them to try on first, and the respiratory therapist working with the patient to try to optimize their usage prior to discharge. And then finally, an outpatient polysomnogram may be considered for confirmation or if needed because of her high residual AHI. So this is just one proposed algorithm that's been put out there for the idea of inpatient diagnosis and treatment in some of these patients with underlying medical conditions. So in summary, sleep disorder breathing is common in hospitalized patients with underlying medical diseases. Having associated obstructive sleep apnea can significantly impact your hospital readmission rate, as we have shown. And compliance with CPAP therapy seems to decrease the readmissions and actually possibly, based on more recent data, affect mortality in these patients with chronic medical diseases. So in conclusion, based on all of this evidence, a structured program designed to diagnose and initiate treatment of obstructive sleep apnea in hospitalized patients can potentially improve patient outcome and decrease overall medical costs. So I'd like to thank you for your attention. This is the conclusion of my presentation today, and I'm going to give it back to Dr. Weaver that will pick up the program from here.
Thank you, Dr. Kratchman. That was a very interesting and thought-provoking presentation. I would like to remind the audience how they can obtain their CEs for this activity. This educational activity is approved for 1 contact hour. To obtain CE credits, please go to saxtesting.com/BO. You will need to register at the site. Please complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Support for this educational activity is provided by Philips. An archive on-demand version will be available on betteroutcomes.org. An email will be sent to all registrants when it is available, and the on-demand version will be accredited for nurses and respiratory therapists. At this time, I would like to discuss a couple of questions here that have been sent in by some of the attendants. The first is from Diane. The question for Dr. Kratchman is, for coverage of CPAP devices, does Medicare recognize polysomnogram testing administered during the inpatient stay?
Well, Diane, that is a very good question. As of now, reimbursement, by Medicare is, purely for outpatient testing, whether it's a home sleep test or an in-lab polysomnogram, unfortunately. And this is one of the things that, the future of sleep medicine needs to look at, whether there should be reimbursement. Right now, in programs like ours, that when we do, especially in our heart failure population, do inpatient testing, we're not getting reimbursed for that sleep test, but we're really trying to optimize patient care and initiate therapy in trying to address some of these readmission rates. A lot of times the home companies will be helpful in allowing device to be given to these patients on discharge, as long as there is some more formal testing being done after they've been discharged. So it's a very good question and something that needs to be addressed, because right now there is no reimbursement for inpatient testing.
Secondly, another question is from Catherine. Do you think that removal of tonsils or adenoids and the uvula, along with internal diaphragmatic pacers, can make people more compliant and decrease the cardiovascular effects of OSA.
Well, Catherine, as far as like tonsillectomy or UPPP, that is used as a surgical treatment for obstructive sleep apnea, it may not necessarily improve compliance with CPAP therapy, which is still the primary treatment option for most of these patients with obstructive sleep apnea. And especially in these inpatients that we've been talking about today that have underlying COPD or congestive heart failure, this patient population, as far as being surgical candidates for treatment, surgical options for sleep apnea, are much less likely. Their older age and their underlying medical illness would probably prohibit them from having that as a treatment option. And it's really kind of a secondary treatment consideration, especially in this population.
Great. Another question from Diane. Considering the high rate of sleep disorders among inpatients, how often are they worked up and treated for those disorders?
Well, Diane, that's a good question. Again, as I showed you in the beginning of the talk, it seems like the prevalence of sleep disorder breathing is quite high. And I suspect, and probably think I'm correct, most of these patients come in the hospital, get treated and discharged, and the majority are probably not seen then as an outpatient for consideration, do they have obstructive sleep apnea? Now, today it's better than it was, let's say, 10 years ago with the house staff or the nurses or respiratory therapists alerting the house staff, hey, this guy, he seems like he might be someone who has sleep apnea. And then the house staff or the attending taking that advice from the nurse or respiratory therapist would say, look, there's some suspicion you have sleep apnea. On discharge, we've made you an appointment to see a sleep specialist in the clinic. Those patients are captured, but think about the number of patients that probably are discharged and are never seen in the sleep clinic, despite the fact from the data I showed you in the beginning of the talk, the suspected high prevalence of sleep disorder breathing in these patients.
Great. And maybe one last question here from Catherine. During the discussion, is compliance defined by the fact that they don't like to wear their CPAP or their BiPAP?
Well, compliance, as we measure it, again, good compliance being considered more than 4 hours a night, greater than 70% of the nights of the month, is a definition that is adopted by Medicare that we follow. But compliance, even less than that, has been shown to have some improvement in their obstructive sleep apnea symptoms and on their underlying disease states. Non-compliance can be caused by many different factors. Mask fitting is just one of them. Some patients, it's just, and that's why we have as an outpatient service here, a CPAP clinic where they'll come in and work with the sleep technicians to find a mask that's more comfortable. It's just like I always say, it's just like going to shop for shoes. If you are going to, get a pair of shoes, you don't just take what they bring out to you, put them on and leave. You try things on until you find something that you like and it's comfortable, and then you buy them. The same thing applies to a CPAP mask. There's so many different masks now that trying different ones on can, find one that you are comfortable with and that you're going to improve your compliance with. But there are many different reasons for non-compliance. One is mask discomfort, the pressure sensation, getting recurrent sinus infections. I mean, there are many different reasons for non-compliance, but we're finding that a lot of times this can be addressed and compliance can be significantly improved.
That's fantastic. Thank you for those answers, Dr. Kratchman. It looks like there are no other questions at this time. And at this point, I'd like to turn the presentation over to Monica for any concluding remarks.
Thank you. Thank you both for your insight and all the information. It's greatly appreciated. And this does conclude today's webinar for today. I would like to remind the audience that there is a survey for you at the conclusion of this webinar, which will pop up immediately, and we would greatly appreciate you sharing your opinions on today's webinar. We value your opinion. And thank you again on behalf of our presenter, Sachs Healthcare Communications, and our sponsor, Philips. I hope you enjoy the rest of the day.